Good afternoon, everyone. Welcome to our webinar on STIs and sexual history taking. My name is Becky Burbidge. I'm the Deputy Chief Executive of FPA, and I'm here with Karin O'Sullivan, our clinical consultant, who we work with closely on all our sexual health information. So today we're going to be running through a few things in the next 30 minutes, and thank you very much for giving up 30 minutes of your lunchtime to be here with us today. We really appreciate it. We're going to give you a bit of background on why we're doing this particular webinar. We're going to give you some recaps on what's new in the information we've produced for FPA and Sexwise about STIs, and we're going to run through some key points to think about when you're taking sexual histories in practice. And then if we have time at the end, there'll be a chance for you to ask some questions, and we'll try and give you the answers. And we will send around kind of written questions and answers to everyone who takes part in the webinar as well. So just very quickly, a little bit of background about Sexwise. So this webinar is produced as part of our Sexwise programme, and Sexwise is a new national resource produced by FPA and funded by Public Health England to give the public honest advice about contraception, pregnancy, STIs and pleasure. And as part of that, we have our Sexwise for Professionals programme to support professionals with updates and resources around sexual and reproductive health. And why we thought it was timely to do a webinar on STIs and sexual history taking. So, well, a few reasons really. The STI rate in the UK is still really high. I think in England alone there was 420,000 STIs diagnosed in 2016, which are the most recent figures available. And at Sexwise, one of our aims is to really improve awareness and education around sexually transmitted infections, testing, and things to look out for. And ultimately, we obviously want to see that rate come down. But we know we're all operating in a very challenging climate at the minute. There's been a lot of cuts and change to services. There's reduced services in many areas, meaning if you're maybe in a primary care setting or a young people's service, you're more likely to perhaps see people with STIs coming in where they would previously have gone to clinics. And we've also seen kind of a real move to encourage asymptomatic patients to take part in online testing, and that's kind of a big shift that's going on at the moment. And we also just wanted to let you know a bit about kind of what's changed in our information. We update our STI information on a rolling basis, and there's been various changes that we've made in the last kind of year or so, and so we just wanted to flag up some of those, as well as kind of giving you some helpful hints on sexual history taking. So as I mentioned, FPA and Sexwise cover information on 10 common STIs and vaginal infections, and we update that on a rolling basis. So we've been busy kind of over the last year or so since we developed the Sexwise programme, doing a big review and updates of all our information, making sure we're up to date with current guidance and thinking. And so we're going to just run through a few updates that we've made to information about gonorrhea, genital herpes, non-gonococcal urethritis, syphilis and HIV. And to do that, I'm going to hand over to Karin. As I said, she's our clinical lead here and has many, many years' experience working in sexual health. So over to Karin.
Hi, so I thought we would start with gonorrhea. Gonorrhea accounted for 9% of STI diagnoses in 2016, and young people still bear the burden of sexual ill health, with 50% of those diagnoses in young people aged 15 to 24. However, there are other groups that are also disproportionately affected by gonorrhea, and they include men who have sex with men and people from black and minority ethnic backgrounds. So it's really important to be aware of the at-risk groups, but also to be able to look at everybody that comes in and think about sexual history taking to work out if it's relevant to the particular person that's in front of you, and not just look at the at-risk groups. So we've updated our gonorrhea leaflet recently. Antibiotic resistance is a growing concern, and the World Health Organization have actually put out medicines that are at risk, and the antibiotic resistance for gonorrhea is highlighted as one of the at-risk areas. And the World Health Organization does say that new antibiotics urgently need to be developed to treat gonorrhea in the near future. And this week, hot off the press, Public Health England announced a UK case of gonorrhea with a high level of resistance to azithromycin and to ceftriaxone, which are the two antibiotics recommended as first-line treatment at the moment. And this case had been acquired abroad. There have been some cases of azithromycin resistance since around 2015 in the UK, but this is the first time that we've seen the resistance to ceftriaxone as well. The reason that azithromycin was first introduced as co-treatment was to protect the ceftriaxone. So this is a worrying update. BASH guidelines on gonorrhea are due to be updated shortly, and the FPA leaflet will again be reviewed following this to see if there's any changes that we need to put into the leaflet, but we'll be looking closely at the BASH guidelines when they come out. It's just really for people to be really aware that this is an area of concern, highlighted by World Health Organization worldwide, but also is relevant in the UK. So please do keep your eyes out for any updated information that comes out. So our info stresses that patients must have both the injection and the tablets on the same day. And as I've said before, this is to try and protect the increased likelihood of resistance to ceftriaxone, which at the moment is still effective in treating gonorrhea, apart from this first case with the high level resistance that we've had recently. Online testing is available and can be encouraged for asymptomatic patients, and certainly with cuts to services, asymptomatic screening is something that's more prevalent and people are using. But people with symptoms should always visit a clinic, and there are some concerns that patients using paid for online testing services may not always be given the recommended treatment, and this is again where there is the concern about antibiotic resistance. So if you've got a patient that comes to you and says that they've used online testing and have taken treatment, it's worth checking out what treatment they had and what they were taking or given at the time. So the reason it's relevant to everybody is that around 5% of gonorrhea diagnoses are made in general practice, and GPs should refer all suspected cases of gonorrhea to GUM services for appropriate management. And this is according to the Public Health England guidance, and this is to really look at preventing resistance emerging, because it is an area that as I said, is of concern at the moment. And commissioners should ensure that sexual health care pathways enable prompt diagnosis, culture for susceptibility testing, effective treatment, test of cure, partner notification, and a full sexually transmitted infection screen. So this would be really important to help to protect the antibiotics that we've got left that are still effective at the moment. I just want to move on to genital herpes now. So again, looking at our at-risk groups, 42% of the diagnoses in 2016 were in the 16 to 24-year-olds. So again, young people are bearing the burden of ill health around sexually transmitted infections. There is a huge amount of worry and stigma around genital herpes from the general population. So it's important to really reassure patients that it's common and it can be managed. And when I'm discussing this with patients, I usually talk about likening herpes. It's the same family as chickenpox, and you're not embarrassed to tell partners that you've had chickenpox in the past, and then you can get shingles when you're older, following on from chickenpox. So if you have herpes and then you get a recurrence of herpes, it's really common, it's easily to treat, and it's really important to just try and reassure patients that it's part of being human to come in contact with viruses. And we don't worry about telling people that we've had a cold or telling people that we've had chickenpox in the past. So really try and remove the worry and stigma that patients experience around herpes. Genital herpes can be treated easily in primary care. It doesn't necessarily need to be referred to GUM. And one of the pieces of guidance, the references that we've got for you later, is the Royal College of General Practitioners guidance, which really, the guidance is really good. So if you don't have a copy of that, then do follow it up and have one available in general practice. But it is important to check for other STIs, and especially blood tests for syphilis and HIV. This is to ensure that you're not misdiagnosing and missing a syphilis diagnosis rather than assuming that it's herpes. So it's really important to never make assumptions, but to do the relevant tests. And be aware of guidelines in managing herpes in pregnancy. It's important to liaise with obstetrician and gynecology colleagues and GUM colleagues, because it might be important to start suppressive therapy from about 36 weeks of pregnancy to reduce the possibility of an outbreak when a patient is due to give birth. And always give advice on safer sex. So it can be a consultation that takes slightly longer than the normal consultation time, but if you do it right first time, then removes the stigma and worry and gives patients a lot more confidence to continue to live with their diagnosis. Another leaflet that we've updated very recently is our leaflet on non-gonococcal urethritis, and the name change is in line with BASH guidance. So it used to be non-specific urethritis, but now we use the term non-gonococcal urethritis. NGU only affects people with a penis and may have different causes. So different organisms can cause the infection, but the most commonly diagnosed cause of NGU is still chlamydia. So that's what we treat it with until we know otherwise. So another common cause of NGU is Mycoplasma Genitalium, and this is something that we're going to be hearing a lot more about in the future. And BASH are due to produce a new guidance on M. genitalia, Mycoplasma genitalia, later this year. And Sexwise FPA patient information will follow production of this guidance. So it may be that you see a new leaflet being developed. But we're in close consultation with BASH about the best way to get this information out. So do watch this space. Mycoplasma genitalium does affect all genders and not just people with a penis. Tests are becoming more widely available. And one of the reasons that we are talking about it is that there are concerns about antibiotic resistance. So when we're treating NGU, for example, if the infection doesn't clear or people still have symptoms, then it might be that it's a problem with the antibiotics, which is why we're looking much more closely at Mycoplasma genitalium as being the possible cause of symptoms in people with non-gonococcal urethritis. So again, do watch this space. We'll be having new guidance out later this summer. So moving on to talk a little bit about syphilis. Syphilis diagnoses are on the rise. So in 2016 there were 5,920 diagnoses, which is a 12% increase on 2015 and the largest number of diagnoses reported since 1949. However, overall numbers are low compared to other STIs. So it's really important to just be aware that syphilis is out there, and it's important to look out for signs and symptoms. It's easy to misdiagnose, as could be confused with herpes simplex virus. Symptoms of the ulcers can look very similar. So again, just to highlight that if you're looking at ulcers as one of the symptoms, it's really important to do blood tests for bloodborne virus, so for syphilis, and also for HIV. So these should be normalised standard tests for anybody that's coming in with concerns about STIs. It's also important to ask about previous symptoms when taking a history, because patients may come in complaining about one thing, and a couple of weeks ago they might have had other symptoms which are important for you to look at. And also ask about previous tests, and if people have been tested previously for syphilis, if you're expecting or thinking that might be one of your differential diagnoses. Ask if people have been treated for syphilis before. It can be really important to note that down for the lab when you're sending the tests off. Again, online and self-sampling testing is now fairly widely available for people without symptoms, and we're going to be seeing much more of this in the future with changes in service provision. So online testing and self-sampling is going to be much easier to access in the future, but it's important to stress again that it's for people without symptoms. So in some ways, you're worried well, because there can be a lot of undiagnosed STIs in the community, and it's really important that we get people to just accept that it's a normal part of going for a checkup. It's something that if they're looking after their health, that they should be able to access those services easily. Syphilis can cause problems in pregnancy, so it's a routine part of antenatal screening to offer pregnant women a blood test for syphilis. But it is important that they're tested again if there's a change of partner, or otherwise, if they've been otherwise at risk during the pregnancy. So one-off test is great, but it's important to continue to talk to people about sexual health on an ongoing basis. HIV, so really lots of positive developments in the last few years, and this is a rapidly changing area. And I think that we're getting somewhere with normalising testing for HIV now, so it's much more acceptable for patients to be offered tests by health professionals and for them to also say yes to testing. Home testing kits and self-sampling kits are quite widely available. And it's really important that we look at this, because there's been such positive changes in things like treatment as prevention. Effective treatment can suppress the virus in the body so that it can't be transmitted. If people have an undetectable viral load, it's now untransmittable. So U equals U, and this is a really important message to get across. If people have an undetectable viral load, then it's untransmissible, so they can't pass HIV to somebody else, and we really do need to look at people that are on prevention treatment. There's been one of the major key changes in HIV. Other areas around HIV, I'm hoping that people are all aware of post-exposure prophylaxis. This is an emergency treatment that can be taken within 72 hours of exposure to HIV to prevent infection. And it's important that patients are signposted to GUM, A&E for assessment of risk, so that they can take PEP within 72 hours of the risk that they're concerned about. And make sure that you've got referral pathways to A&E or GUM, so that you can know where patients are going to go to, know what your local services are like, what their opening hours are, and if you can phone them to say we're sending someone to you, so that the services are expecting them, along with the referral letter, then that's really helpful. So do make contact with your local providers. And then there's also PrEP, so the pre-exposure prophylaxis. Patients may be on PrEP that they've bought privately, or they may be part of an NHS trial. There's a number of trials up and down the country, so clinical settings are linked to universities to look at the pre-exposure prophylaxis treatment. And this is ongoing, so there's still places available for patients to be part of the trial in various parts of the country, and it's a wide variety of different patients that can be part of that trial. So if you're not aware of it, then please again contact your local GUM services to find out what's going on in your area. So testing and treatment tips. For up-to-date guidance on the diagnosis and treatment regimes, the BASH guidance is very easy to access. I have that stored as a favourite on my desktop, on my computer, and look things up regularly. And the RC, the Royal College of General Practitioner guidance on STIs in primary care, is a very readable and accessible document. So again, I have that saved as a favourite on my desktop. So we've got details of that reference at the end of this webinar, but please do have a look at those. Something that I do for bedtime reading or for fun. So I know not everybody does, but I find those really helpful. Testing will always depend on what's available locally, so it's really important that you know your local referral pathways, and be aware that newer tests may be coming out for Trichomonas vaginalis and Mycoplasma Genitalium. Some of the tests that we've used to find TV up to now have not been very effective, but we've got new NATs, the nucleic acid amplification tests, which are much better, and they are becoming more widely available. So local labs, again, know what your lab is using, which swabs that you should be using, and as I said, Mycoplasma Genitalium is something that we'll be looking for much more in the near future. So I'm looking forward to the guidance coming out from BASH about that later this year. If you're ever unsure or concerned, then please do signpost to GUM. And because we've talked about the gonorrhea resistance issue or problems, always refer to patients to GUM for gonorrhea management when that's been diagnosed in primary care. So moving very briefly on to sexual history taking, why is it important? It's really important that you get the right information so that nothing is missed. Asking the right questions helps you to get the right question to the right test to the right person at the right time, and to treat them holistically. So this will enable you to check, trace, and treat to avoid reinfection, and gives real opportunities to discuss prevention, protection, condom use, and safer sex. So again, sexual history taking should be normalised. It should be part of every single consultation, particularly working in general practice. There's so many opportunities where you could be asking patients about sexual health. So this is the kind of hand on the doorknob scenario. Patients will come in and ask you about headaches, for example, when what they really want to know is actually I'm having problems with sex, and would really like to talk about it. So look out for those hand on the doorknob conversations that patients will want to have. If you ask the questions, they'll be happy to give you some answers. So some things to ask about: relevant signs and symptoms, partners, type of sex. You want to know what, when, and who with. So one of the examples that I would use is when you have sex, is that with men, women, or both? Any condom use? And HIV risk assessment. Again, this is about normalising. So ask everybody the same questions. So treat everybody the same. Ask them questions about sex, not just looking at, we've talked about young people being an at-risk population, but don't just ask people for a particular age, but ask everybody, because if you do normalise the conversation, signpost that you're going to, it would be helpful for me to ask you some questions about sex. Is that okay with you? And patients are often delighted that it's the health professional that's raised the issue, rather than patients having to stumble their way through asking us. So again, treat everyone the same, ask everyone questions, don't make assumptions, and give it a go. Don't phrase questions as assumptions. So use open-ended questions or motivational interviewing questions. Motivational questions are really helpful when we're looking at sexual health. So don't assume, I'm sure you're sensible and use condoms. It doesn't give the patient any place to go to disagree with you. But do say, when you last had sex, did you use a condom? Or out of the last 10 times you had sex, how many times did you use a condom? And then on a scale of 1 to 10, how confident do you feel to use a condom? So this gives you something to work at. You've worked out that they only use condoms 50% of the time, but actually that's because they're not very confident with using condoms. Or they'll use condoms 90% of the time, and they're very confident about condoms. So what happens the other 1 in 10 times when you didn't use a condom? Was it because you didn't have condoms? So it gives you something to work on. So it's a really useful technique. Always be aware of safeguarding issues. Be aware of consent and safeguarding concerns when you're talking about sexual health. And a question that I always ask is, when did you last have sex? And was that sex that you wanted and agreed to? Could you say no to sex that you didn't want? As part of our Sexual Health Week, we did do some tips for health professionals. So it's got some of the wording and some of the suggested questions in that, and that's available on our Sexwise website, which Becky will talk a little bit more about in a moment. And finally, from me, sexual history taking tips. Send positive messages, give patients positive reinforcement about testing and looking after their sexual health. And I know you all do this, but ensure you offer a welcoming environment to promote testing. And can you also promote your local online testing service for your asymptomatic patients? So that was a real quick whiz through, and I'm just going to hand to Becky now to finish off.
Oh, thanks, Karin. So I hope you find that helpful. So it was a very quick run through in the half an hour that we've got. And we've probably got time for about 1 or maybe 2 questions. So you should just find in a moment that a little chat box is popping up on your screen. And you can use that to, just fiddling with it now, you can use that to send us any questions if you've got any, and we'll just wait to see if anything is coming through. Okay, we're getting a few through here now. So just while we wait to see if more come through, I'll just quickly run you through the sources of information that we've got. So we'll send round a recording to the webinar after this, so don't worry about scribbling all these down now. They will be available later. But we've just put together a little list of stuff that we've talked about in the webinar and some other useful resources. So there's the it's not RCOG, I think it's our CGP, STIs in primary care documents, our tips for professionals that we put together as part of last year's Sexual Health Week, and a few other bits and pieces there. So they will send around these slides. So I think we have just got time for 1 or 2 of these questions now. So I'm just going to hand you back over to Karin, who will read out one of the questions and give the answer.
Okay, so one of the questions, what are the signs and symptoms of gonorrhea? I think when we're talking about signs and symptoms, it's really important to remember that, so for example, 50% of men who have gonorrhea will not have symptoms. So it's not so much signs and symptoms as looking at the sexual behaviour, which goes back to sexual history taking. So when did you last have sex? Who was that with? Did you use condoms? Those sorts of questions, we'll be looking at that. And if a patient has come worried, then it's really worth looking at the sexual history and remembering that people don't always get signs and symptoms. People are more likely to attend if they do have symptoms, so they can have quite a nasty discharge. But the main message I want to get across is that patients may not have any symptoms. We've had a couple of other questions, but we've run out of time, so we will be answering those and sending both the questions and the answers following on from this. So I'm just going to hand back to Becky to say thank you and finish off for today.
Thanks, everyone. Yeah, apologies we didn't have time to get through more of those questions. We've run a little bit over. So as Karin says, we'll do a roundup and send that round, and we'll send round the recording after Easter as well. So I just wanted to say thank you very much for taking some time out of your day to attend the webinar. I hope you found it useful. If you want a more in-depth look at STIs, FPA is running a training course in September. It's a one-day introduction to STIs, and you can find information about that on our website, fpa.org.uk/training. If you're not already registered for our professionals information updates, do sign up. You can sign up either through the FPA website or the Sexwise website, and just means we can let you know when we've got more free events like this, when we've got any free resources coming up, and we also keep you up to date with all of our information updates. So I just wanted to say thank you very much for attending. I think once I end the event in a moment, you should get a little thing that pops up and asks you to give feedback. So please do give feedback so that we can improve in the future. We will be running more Sexwise webinars probably later this year, so keep an eye out for those as well. And I hope you all have a really good bank holiday. So thank you very much, and hopefully catch up with you soon.